Hello, my friend, and welcome to the podcast. Today, I want to do something different on the podcast. My goal and intent for today is to really brag on and give a lot of kudos to one of the best podcasts I listened to in a long time. And that is Peter Attia's podcast with Dr. Rachel Rubin. The title of the podcast is Women's Sexual Health, Menopause, and HRT. And so if you're watching on YouTube, I have the little thumbnail of what that podcast looks like. And I have to tell you, I listened to this podcast and I sent it to a lot of my friends. I sent it to the people that are in midlife makeover and all my clients. It was so well done, phenomenal. And the amount of information in this 2 hour plus podcast, I had to listen to it several times to get it all down and for it to sink in. And here's the thing, I am already familiar with bioidentical hormone replacement therapy. I am the classic patient going through perimenopause and into menopause right now. And I found so much value in this podcast that I want you to go listen to it. If you are a woman in perimenopause or menopause and beyond, it is essential that you listen to it. It really highlights the disservice, the great disservice we've done with the Women's Health Initiative in broadcasting that trial before the results and before the data was fully ready to be interpreted by the scientists. And once all of that information had been in the press release and got out so early before all the research was really done and data was looked at, all the harm that we've done that we weren't able to pull back and retract. Even though there has been retraction statements and other things published that don't go along and support those results, there is widespread fear about hormone replacement therapy in women in the perimenopause, menopause timeframe. And I love how they get super fired up and heated about it. I'm a fired up pharmacist as well over this topic. And they talk about how their blood pressure goes up every time, somebody is fearful and talking about the Women's Health Initiative, which remind you is 23 years ago. And yet nobody's talking about all the latest data in the past 20 years that totally negate what came out in 2002. And so we have a whole bunch of untrained practitioners and physicians that are not offering the most optimal care for women in this important transition. They also compared and contrasted now that if this was a male condition, how society would respond differently, how this would be more eager to find out the results and more well studied. But since it's a condition in females, that there's not a lot of money and not a lot of data and not a lot of research and support put into it. And then there's also barriers, not just with the finance and the interest, but the approvals at the FDA and what went down with male products versus female products. And they talk a lot about the sociological part of that and societal's part in that. It really highlighted for me how I want to be more front and center and talk about this topic a lot more. I want to be part of that menopause they were talking about, where you just want to talk about menopause from the rooftops. You want women to get the most up-to-date and most accurate information, because what is flying around out there right now, if you're not in these circles, is a lot of misinformation, and it's bad information. It's harmful to your health when your health can be optimized. And so I wanted to take this podcast and commend Peter Attia and Rachel Rubin. And I'd love, Dr. Rubin, if you're listening, for you to come on my podcast. We're going to try to get you on my podcast, if you will. But it was phenomenal. It was so well done. And I really want to commend the both of you for that excellent episode. And then just pull some of the highlights here if you don't have the 2 hours and some time to listen to that. I'm also going to share some stories of patients and clients that I've worked with and how I've helped them to find out if they'd be a good candidate for bioidentical hormone replacement therapy. I think every woman should consider this decision for themselves. It's not a blanketed statement that we should all be on it, but make sure that you are getting the correct information about the risk and the harms. Because what I hear out there in the world is that there's a lot of harm. When you look at the research, there's minimal harm. there's minimal risk with going on bioidentical hormone replacement therapy. And I also understand that if you are not a pharmacist or not in medicine, a lot of this information can sound confusing. And so I want to give you some tips while I'm going through this podcast. And I also help my clients decide, how to advocate for themselves. Because if this is something that you believe in, and I want to present to you some of the data, it is astonishing how this can change your life, meaning your symptomatology. And I see so many of my clients being shushed away by practitioners that don't understand this information, aren't willing to have a discussion about this information, and really just close them down where they feel deflated. And I have helped so many women find good practitioners and ways to get on bioidentical hormone therapy if they want to be on it, because the value you are going to hear is tremendous. And it doesn't start in menopause. It starts in perimenopause. And I'm going to show you a SWAN study, which they started following women between ages of 42 and 52, and some of the dramatic effects that you can see early on by using bioidentical hormone replacement therapy. So with that, let's dive into some of the key things that they were mentioning. To begin, I just want to address hormones, right? When I talk about hormones, I talk about all the hormones. So in my metabolic makeover program for women in midlife, we talk about all the hormones. We talk about the sex hormones as well. But in that program, you're going to learn about your thyroid. You're going to learn about your microbiome. You're going to learn about insulin. You're going to learn about how to take care of not gaining weight. If you are of the woman that wants to lose weight, you're going to learn what's most effective above the age of 40 to lose weight. You're also going to learn about estrogen, progesterone, and testosterone. So in midlife makeover, we are talking about everything that goes on, because that perimenopause to menopause transition is so important and so wonky for people. And we're seeing it now from, Oprah's talking about it, Halle Berry's talking about it. We got great celebrities in this space finally talking and bringing attention to menopause. And what we're really talking about is this midlife shift that happens for women. And we need women screaming it from their rooftops, because a lot of women before us have suffered in silence and weren't offered the medications and the ways that they could deal with this to extend their life and to improve the quality of their life. And so I want to share with you ways to do that on today's podcast. All right. So when we're talking about hormone therapy for this podcast, I'm going to be focusing on the 3 sex hormones: the estradiol, the progesterone, and the testosterone. Why is it that when you get to about 40, 50, and you want to go on hormone therapy, there's so much fear, people push back, don't want to do it, or get scared of it, whether it's patient or practitioner. But yet when we have 20-year-olds that want to go on birth control, it's not a problem. The prescription gets written right away. Oh yeah, there's familiarity. The doctors already know how to write it. The patients are like, yeah, we don't even think about birth control pills. But birth control pills contain so much more estrogen and progesterone than what we're talking about for the menopausal woman. So much higher doses that we just give to anybody, and everybody writes them from primary care to whatever doctor. But yet to go on hormone replacement therapy, which are much smaller doses for women whose bodies are screaming for them, nobody seems to know how to write the prescription. Nobody really wants to talk about it. Some of the patients are fearful. Some of the practitioners are fearful. And there's just like a dearth of knowledge. And we treat it like we want to take higher doses. And it's like, no, we're just replenishing back what the system is already losing. And so I love Dr. Rubin's example. She says, the gas tank is just emptying. Our ovaries are making the estrogen and the progesterone, and our testosterone, they're making it. And somewhere in the mid 40s or beyond, we're just not getting a high enough gas in the tank. And it's running on low, running on low, running on low. And then all of a sudden the woman feels terrible. They don't feel like themselves. Their brain fog, they can't find words. They walk into a room and they don't know why they're there. They forget why they're there. And maybe their cholesterol's starting to go up, or maybe they're starting to get weight gain around the waist, and maybe they're starting to feel wimpy or weepy, not wimpy, maybe wimpy, right? Maybe they're losing muscle mass and they're weepy and they're crying and they're mood swinging and they're angry and then they're in rage mode and they're like, I don't understand myself. Who am I? I used to love my job and now I don't. I'm thinking about quitting or retiring early or changing to a different career. Things bother me more than they used to. Used to be able to handle stress. Now I feel like I fall apart. These are all symptoms that women experience because the tank is getting empty. The estrogen, the progesterone, and the testosterone is getting low. And yet, what do we talk about in menopause? We don't talk about those symptoms. What do you hear? Oh, my menopause was easy. I didn't have hot flashes or night sweats. Or my menopause was horrible. I had terrible hot flashes and night sweats. Like there's only 2 symptoms in vaginal dryness. There's 3. No. Perimenopause and menopause has all kinds of symptoms, over 50 of them. Irritability, crankiness, like all kinds of symptoms that I've just named. I didn't even talk about joint pain. I didn't talk about eye dryness. Women's their eyes get dry. The lubrication is not there. They don't have the estradiol, so it's not lubricating the vagina. It's not lubricating the eyeballs. It's not lubricating the joints. People get plantar fasciitis. People get frozen shoulder, right? All these joint things start to come upon us, and we're wondering like, oh my gosh, I feel like I'm, aging overnight. And it can feel like that for women because men go through andropause and it's much of a slower decline. Women, it's wonky, 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 and then it's like a slam, you go off a cliff. So it's not the same. The aging process is not the same for females as it is for males, right? So we can't treat females like we treat males. That's not accurate. Our biology is different. And so I want you to understand that. And that's why I'm so passionate about that podcast episode. Please go listen to it if you have time. One key thing that I loved that they talked about is that, we focus on the risks of going on bioidentical hormone replacement therapy. And, I'm passionate about this. I joined a program to get certified so I can understand bioidentical hormone replacement therapy and be able to prescribe it. Yep, I'm in a training program learning so much about it. It is awesome. And they talk about the risks of bioidentical hormone replacement therapy, and there's very little compared to what is out there in society from that Women's Health Initiative back in 2002. But what they highlight in this podcast episode is they say, we don't really talk about the risks of not going on bioidentical hormone replacement therapy. And then Dr. Rubin went through the list and I said, oh my gosh, I have to stop and rewind this and take down notes. Listen to all the things that are risks that go up if women don't take hormone replacement therapy. Increased risk of urinary tract infections, particularly recurrent urinary tract infections. Increased risk of osteoporosis, increased risk of falls and fractures, higher risk of Alzheimer's and dementia, increased risk of cardiovascular disease as well as heart attacks, increased risk of colon cancer, increased risk of painful sex, pelvic pain, vaginal dryness, increased risk of not being able to have an orgasm or difficulty obtaining an orgasm, no libido, increased risk of depression and anxiety, weepiness and irritability, increased risk of blood pressure increases, increased risk of belly fat, increased risk of diabetes, increased risk of cholesterol going up, and an increased risk of stress incontinence, increased risk of joint pain, increased risk of eye dryness. I didn't even mention hot flashes, night sweats. Do you hear, like, your whole entire system from your brain right down to your pelvic area, right? It all needs estrogen and progesterone and testosterone because the tank starts to run empty. And that's why women start to not feel like themselves. And I'm loving all of the attention that is getting, at least in my newsfeed, because I keep clicking on it and I keep hearting Mary Claire Haver, I keep hearting Kelly Casperson and all the people in this space, because I know women need to hear this message. Not only women, but the doctors and the practitioners. So We talk about how the standard of care before the Women's Health Initiative, which is that pivotal trial that painted hormones negatively and made everybody jump off them and flee and not turn back and look at them. Everybody got so fearful. And Peter Attia wrote down, quote, he called it the greatest injustice to modern medicine in our lifetime was that trial, the misinterpretation of that trial, because it was misinterpreted when it first came out. When they actually went and sat with the data and analyzed it, the damage had already been done. So when they put out the actual report, the damage had already been done. Everybody was so fearful, stopped prescribing, women came off their hormones, and it's taken years, and I'd argue decades, to come back from that. So let's hear, after 23 years since that trial was published. So they did the stats. They were saying that in the 80s and the 90s, 40% of women were on hormone replacement therapy. 40%. Where are we today? 23 years later, after the Women's Health Initiative, nowhere near 40%. Less than 4% of women who could be taking bioidentical hormone replacement therapy are actually on it. And I am part of that 4%. So less than 4%. So that damage is still around. We are nowhere near where we used to be in terms of hormone replacement therapy. And I'm not advocating everybody goes on it, but I am advocating that we should be knowledgeable on exactly how does it benefit us, and if we want to go on it, to be able to be offered it. And that's not happening in physician offices across the United States. It is not being offered to most women. Greatest disservice to modern medicine in our lifetime. 40% were on hormones, now less than 4%. So they have a boxed label on estradiol, and they talk a lot about that. So that's one of the estrogen products. And they had a box label on testosterone. Well, that box label just came off a couple months ago, thankfully to the Traverse trial, which they talk about in that podcast. The box label on estradiol no longer belongs there because, like I said, we refuted and took back a lot of those claims that were inaccurate. And the FDA is not willing to take off that box labeling. Dr. Rubin talks about her fight and how it went down and what the FDA now requires, which is a greater stringent guideline compared to what testosterone had. So you see that the goalpost is moving, and people just don't have the cash just to keep pouring into to clear up falsified, inaccurate data on a package insert. And when you read that black box, physicians get worried, patients get worried when erroneously it shouldn't be there anymore. So fascinating to hear the sociology behind this and how the money goes and the money flows. So interesting. When we go through this big hormonal shift in perimenopause and menopause, that women should be offered to put back the hormones that they are now not receiving. And if we're not getting it from our physician office or it's not being offered, there are going to be these industries that pop up to be able to meet that need because patients want to be on them. Patients who keep up with the literature like, no, this is good. Listen to the litany of things that I get protected from if I go on hormone replacement therapy. So they talk about these pop-up industries, these hormone clinics, these pellet clinics. And I really love how they highlighted what are some of the red flags you should look for when evaluating if you should go to one of these pop-up clinics. In one of those, is pellet clinics, and be careful if they're about your profitability and charging you a lot of money rather than just about your health and getting you to physiologic levels. And I know I worked with a client who was at one of these pellet mills and was getting pellets, and her levels were super high when we actually looked at them and sat down, and she had no idea, right? She had no idea how to monitor these or look at these or determine if she was getting enough or not enough hormone. And so when we sat down with her labs and started looking at it, she's like, wow, I don't want to be doing this anymore. And now wonder why I get these certain set of symptoms because my levels are way higher than they need to be. And that's why I see that. And then when the pellet wears off, the hormone level is too low. So it's not the best formulation for certain patients. And so you really want to make sure you're picking the right practice and the right formulation that's going to work for what you're looking for with these medicines. Because you can overdo it, you can underdo it. And many different practices have different philosophies. So you just want to make sure that you are in alignment with the philosophy and the formulation that you're getting. So I love how they talked about the red flags to look for. So listen to that episode for that. I love how Dr. Peter Attia talks about how when was advocating for bioidentical hormone replacement therapy even 10 years ago, and still today he gets scolded by other physicians, like, they're just not willing to look at the latest data, they're not willing to be educated, and scolding somebody isn't the way to learn. And really just having a conversation, hey, let's look at the data, here's what I see, what do you see, and being able to talk about it in an educated, polite way is the best way to learn and help others learn as well. So I love how he talks about that, because in my own experience, I've been to physician practices where I felt I was being a little forceful because I was getting scolded for advocating for myself. So I want to share with you, this just happened last month to me. I was looking for a new practitioner, and I wanted someone very versed in hormone replacement therapy because I'm on that. And I want them to be a supporter and to be able to write the prescription, right? And go through my insurance and all the things that we look for when we are a knowledgeable client or patient. So I went to this one practitioner, vetted her very well on the website, saw that she believed in bioidentical hormone replacement therapy. She got extra training in it, learned all about her. I had a friend that also recommended her and said she's wonderful. So here's my story. I go in and I carry in information and data because I like to be knowledgeable. I'm open to learning as well. So I'm a new patient and I come in on all of the things, my testosterone, my estrogen, my progesterone. And right out of the gate, I thought it was going to be this amazing relationship that we were going to build. And right out of the gate, I get chastised. Why are you on all these medicines? You're in perimenopause. You're still cycling, right? And I'm like, yes, but I want to be on hormone replacement therapy because of all the literature I've been reading. And of course, I have my little literature book. And so she's telling me she doesn't start people on it until they're in menopause because the benefit is la, 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 la. So I bring up the SWAN study. And for those of you in perimenopause, so that could be as early as 42 in the SWAN study, they started enrolling patients between 42 and 52. And they started reporting on how their health was functioning or dysfunctioning. And so they have this great fact sheet on bone health. And as a Caucasian woman with my ancestry, I know I am at significant risk of osteoporosis. I know based on my demographics, I am at risk of osteoporosis. So I'm very concerned about my bone health. I want to do all I can to maintain it for as long as I can. I don't want to lose bone. So on this fact sheet, it talks about that the year before we hit menopause, right? Menopause is going a whole year without your period. The year before you hit menopause, you have fast bone loss. Bone loss is so fast and significantly fast around the 3 years and continues. You continue to have bone loss in postmenopause, but more slowly. So if you're already 55, 60, right, and it's been 3 years since menopause for you, your bone loss is slower. So right now I'm rapidly losing bone, like fast. So if estrogen has in its package insert that one of its indications is to prevent osteoporosis, do you think I should be starting it at 60? I think I should be starting it when I have the fastest amount of bone loss, which is in perimenopause, right? So if you're still cycling, women, you don't wait till menopause to start these medications if you want full benefit. Now, if you're 60, it's not like you missed the boat, right? You get still benefit, but you're going to get a lot more benefit the earlier you start, which is why I love talking with women in midlife, because losing bone is not for people of old age. Losing bone is a midlife problem. It's a midlife condition. And so I said, oh, the SWAN study and the SWAN fact sheet, and that's why I'm on it. And I said, are you aware of this? And she didn't answer the question. And I said, well, would you like to see the study? And here I've highlighted it for you. And if you see on the YouTube, if you're watching the video, I'm holding up the piece of paper I brought with it's highlighted. And she says, no, thanks. And instantly I thought, oh my gosh, this is not going to go well. Like, I want an open discussion. I want an open dialogue, and I'm being shut down. And she says a few more things that were a little bit concerning to me. They weren't in line with the latest data and the latest research, and they weren't in line with where I wanted to optimize my care. Now, I have to say that I don't back down easily, and it's not that I'm trying to be right. I'm just trying to advocate for my health. And so after an hour and 5 minutes, I walked out of that office and we were cordial. And here's the thing, when she came out of the gates, she thought I shouldn't be on all these medicines. I'm in perimenopause. We start them later. At the end, she agreed with my assessment. And not only that, I was talking about my levels and how I wanted to tweak things. She agreed with that and wanted to increase my levels on some things. So after that hour and some dialogue, right, she came around to like wanting to take me off medication, thinking it's too soon to, oh, I see why you're taking it. Oh, I get that. Oh. And I was talking about levels and where I get data and what I've learned. And it turned out to be an okay appointment. But I was surprised with somebody so educated in this area about her philosophy, and it didn't match mine. I tell you that because go in knowing what you want and keep advocating for what you want and keep pressing for that, especially if it's evidence-based. Now, I've helped a client just 2 weeks ago reach out to her practitioner because she thinks she might have missed the boat on bioidentical hormone replacement therapy. She thinks, I'm already in menopause. I missed the boat. And I'm like, that is not so. Do you want data? I will send it to you. I'll tell you how it's helpful. We crafted a message while I was on the phone on Zoom with her, and she was writing to her physician. I told her to craft it this way so that she can get a sense of, hey, is this physician going to be for it, or is she going to think I missed the boat as well? Because you don't want to be wasting your time. You have energy, you have money, and only goes so far. So you want to make sure that you are finding people who are going to be in your camp and helping you get on the medicines that you want to be on. Lo and behold, she's got an appointment. But what happened before that is she saw her physician's PA, so the physician assistant, and she didn't do any of that training or call the office. I often recommend my patients call the office, kind of get the flavor for what the physician believes in and prescribes, particularly per their case. And when she went to the PA said, oh, so you're feeling wonky, you're feeling tired, you haven't had a period in so long. This is not anything to do with menopause. You're just depressed, and gives her a prescription for an antidepressant. And I said, okay, well, you've got cholesterol that's going up, you've got prediabetes, so just pointing out all the symptoms of menopause, right? Because these all are symptoms of menopause, plus the brain fog, plus not feeling like you want to get out of bed, plus the weepiness, plus the irritability. Like, we're going to put you on an antidepressant, but it's not going to fix the cholesterol and all the other things. Whereas bioidentical hormone replacement therapy has the potential to help in those areas and reduce the risk. So very interesting. So really working with someone who can help advocate for you and get you the studies. And I give my clients studies so they can go to their provider so they are informed and they know what they're asking for. So back to the podcast episode, I love how they talked about halfway in about all the different types of estrogen products that are available on the market. I think a lot of us just think there's just one or two, but there's a whole gamut. And I love hearing that because if you don't want to be on a ring, you don't have to. If you rather be on a patch, if you want to be on a gel, if you want to be on a cream, if you want to be on oral, right? Estrogen comes in all different formulations. And it could come from a traditional pharmacy, or if you want it compounded, you could get it from a compounded pharmacy. So many different ways. And people think it always has to be high price. I find that when I get it, it's not high priced at all. It's terribly cost effective for all the benefit that you get. 100% hands down. So don't assume things unless you really research them. And there are some compounding pharmacies that are cheaper than others, right? So it's knowing where to go and how to ask the right questions so that you can get the most optimal care. What I also love is they talked about, which a lot of patients don't know and a lot of clients don't know, is that, hey, I'm on estrogen. And so I'm getting the bone protection. I'm getting the brain protection. They tease out in that podcast episode, there's systemic estrogen therapy and there's also local estrogen therapy. Systemic estrogen therapy means it goes systemically all throughout your system. It's going to hit your brain, your heart, your vessels, all the good things. It's going to lubricate your eyes, on your skin, all of the things that you would expect. When you use it locally, you don't get that protection of the bone, the heart, the brain, all of that. So depending on how you are using the estrogen and the product you are on, will tell us if it's a localized effect or a systemic effect. So if you're going into your doctor's office, you might want to advocate for the systemic effect if you want all the protection that estrogen has to provide. And then also it gets a little technical. If you're not in this space or a medical practitioner, estrogen, we have, just the name. But as I had, I think Dr. Gersh on the podcast talking about it, estrogen is a family. Underneath the broad category of estrogen are the different types of estrogen. There's E1, E2, and E3. E1, estrone, E2, estradiol, E3, estriol. And the most protective one that we've seen in the literature is the E2 or the estradiol, and that's the one that most people wind up going on, and that's the one most people use because of all the great data and all of the low risk and high reward or much benefit is with estradiol, the E2 product. So knowing the product, knowing the formulation, if it's systemic or local, it's a lot. It can sound like a lot to take in, but once you've done it and once you got versed or you come to somebody like me, I can help you with that so you can figure out what products and what formulations are going to work best for your quality of life and improving your health and lifespan. So a little bit of information to go into it to make sure that you're on the right product. And I'm always loving that it's not a one size fits all. So that's why I don't like to give advice out on Instagram or any of the platforms, is because I really wanted to get to know you, your medical history, your lab work, what we're targeting, what you're willing to do, what you're not willing to do, because that's all going to tie into what kind of product and how we monitor it, how often it gets monitored, and all of that. So it's really an individual discussion. So they also talk about that in the podcast, shy away from these hormone clinics that it's like one size fits all. Everybody gets this dose. They use the example of the pellet. You get this pellet and that's it, right? Everybody coming in starts here, ends here, and it's one size fits all. That would be a red flag for me as well. I would want something individualized to what my body needs and what it requires at this phase of my life. I might need more estrogen right now to protect my bone, and I might need less as I go on, right? I might need less testosterone right now because I'm still making a lot myself. And as I move into my 60s and 70s, I might need more, right? So that one size fits all model, I would be leery of as well. So they talk about that local versus systemic effect. And the other thing I want to point out with that local versus systemic effect is it's in the last half hour of the podcast episode. Dr. Rubin has a just heart-wrenching story about how she lost her mom. But through that example that she was giving and how she educated so many people in the field of medicine on how to prescribe hormones was truly like, I felt a breath of fresh air that somebody cares that much to stay overnight, to train all the physicians, to train the pharmacists, right? To get the best quality of care for her mother, even as she's ending her life. And it was not just about her mother, but also to help so many other women in this arena. She talks about how prescribing hormones shouldn't just be for hormone doctors and hormone specialists. It should be for your primary care physician. It should be for the pulmonologist. It should be for the ICU team, because there's so much benefit to hormones. And she talks about even later in life when you have a catheterized patient and you're reducing the risk of recurrent UTIs. People die of UTIs in their 80s and their 90s. They get sepsis, right? And they're on multiple antibiotics. That's not good. There's lots of side effects from being on antibiotics all the time too, with the gut microbiome. And so how she educated the surgical team, educated the nursing staff, educated the pharmacist on, hey, if we use local therapy, right, we're going to reduce the risk of recurrent UTIs by over 50%. We're going to reduce stress incontinence. We're going to reduce pelvic pain, reduce urinary leakage. I mean, just think of how many women in their older age are in diapers and have urinary leakage and stress incontinence. And by using estradiol cream locally, vaginally, you reduce that risk by like 50%. And she was saying what a cost savings this would be to Medicare if we put women who suffer with these conditions on either estradiol or a DHEA product, that we would reduce spending and save Medicare anywhere between $6 and $22 billion. That's billion with a B, my friends. $6 to $22 billion. Because women have stress incontinence, urinary leakage, recurrent urinary tract infections in older age. And by using, she did a study, by using DHEA or local estradiol, you reduce that risk by over 50%. And so I'm a big fan of those products. If you are watching on YouTube on the video, here's estradiol cream. You could get this from any pharmacy. She talks about how it's super cheap, which means shriveling up and getting old, right? Looking like a prune. You want it to be, younger looking, and it's going to maintain that vaginal tissue. It's going to maintain the vaginal pH, which is going to reduce the risk for infections. And so, yes, we can do this to prevent these conditions of aging, right? It's like an anti-aging formulation. So this is only available by prescription. This is not over the counter. However, DHEA is over the counter, and I do have a product on my website, and this is exactly why. Because I use the product, I've recommended it to friends in their 40s, their 50s, their 60s, their 70s, and yes, I even recommend it to somebody in their 80s. And time again, when they use it, they write me back and saying, "Oh my gosh, Sherry, this was magical. My libido's back. I'm no longer have so much vaginal dryness. I got some lubrication and my vagina looks different," right? It's like regrowing. It's looking so much better. And that is the Julva product. I believe in this product so much. This is formulated by Dr. Anna Kabeka. I had her on my podcast, I think last year. And I believed in this product so much that I said, "Anna, you got to give me this. I want to sell it on my website and I want to scream from the rooftops," because this has really brought sexual function back for women who are struggling. And so she has a great video that you can just do a little QR code. It'll scan and it'll just talk about how to apply it. And it brings back a little bit of pep in that area, a little pep to your sex life. And who doesn't want that? So many ways that women can prevent aging or slow down aging, care for our bones, care for our brains, care for our cardiovascular system, care for our vaginas, care about our bodies and the joints and the lubrication. It's all part of this huge hormonal shift that we go through. And don't wait, ladies. Another great part in the last 20 minutes of that podcast talks about, should you stop your hormone replacement therapy, and the misinformation we have about starting hormone replacement therapy beyond 60, where people are told time and time again, "Oh, you missed your window of opportunity. Oh, you're too late to start." And I love the discussion that they have. What can be done for those women who feel or who are told that they've missed that window of opportunity for bioidentical hormone replacement therapy? Oh, hands down, I love that episode. I want to go to listen to it probably a couple more times, because every time I listen to it through, I learn something more and more and more. And I'm just such a thankful, grateful listener to that podcast and the work that they are doing to really manage women's health as when we get to 42, 45 and above. All right, my friend, if you want help with managing your midlife transition and really looking from head to toe on how to improve your metabolic health, it's all metabolic. It all comes back down to the hormones. And again, it's not just the sex hormones that I talk about in midlife makeover, but it's really all of the hormones, including the sex hormones, so that you are educated, so that you can get proper treatment and maybe not even be on certain treatments like an antidepressant if it's not the best option for you and all of your symptoms. I love helping women in that program. All right, my friends, so good to be with you today. Stay epic, and I will see you next week. Thanks for listening to the Health Habits and Epic Living podcast. If you're ready to take the next step to improve your health, wellness, and lifestyle goals, head over to www.epicyou.com and sign up for my weekly newsletter. Again, that's EPICYOU.com. Please note that the information in this podcast is for educational purposes only and does not constitute medical advice.